Dear colleagues, welcome to this course in Targeting in Stereotactic Functional Neurosurgery. The aim of this course is to provide a general introduction to the area. Other lectures and courses are available if you would like to train on how to calculate coordinates, as well as if you would later want to learn how to identify any one of a number of individual targets. These courses on calculations and individual targets can be combined with target practice. A number of investigations with pre-calculated trajectories and targets are available at the website. These can be downloaded together with detailed case guides and used for target practice. However, in the present course, we will focus on general aspects of targeting. The course is based on the lectures above, with targeting, atlas targeting, trajectories, visual anatomical targeting, and identification of the ACPC. I suggest that you start with the first and continue in an orderly fashion. The chapters are short and concise. However, if these should be of any use, it is important that you read, understand, and reflect on the content. Thus read each one of them slowly, and preferably not more than one a day. Let us now start with the background. In my personal opinion, the targeting is the most important and difficult part of the operation. If the targeting is not well done, then there is little hope of a good result. Today we have numerous targets in the brain, but what is really a target? We are often more or less targeting a point based on clinical experience. The target is, however, of course not a point but a volume. There is no reason to assume that a volume should be symmetrical in any way. It is a point that is reasonably easy to accurately identify and that has, when targeted for DBS in clinical experience, provided a good effect. Thus, the target point is not necessarily the point where DBS will provide the best effect. It is a reasonable approximation where an electrode with several contacts will provide a good clinical effect, even if this is not necessarily always achieved from the contact located in the target point. It is further important to realize that the targets are not well defined in the literature. The same name in the literature is not the same as the same target. Different names are used for the same target, and sometimes the same name is used for different targets. The actual distribution of the electrodes within a target will vary. Different contacts and stimulation parameters will affect different structures and volumes of tissue. The foundation for stereotactic functional neurosurgery is our ability to correctly identify and reach the different brain targets. When we do, everyone is happy. When we don't, we get a poor effect and disturbing side effects, and everyone is unhappy. So, how big is the problem with misplaced electrodes? Well, I believe this to be a huge problem today. In this recent study of more than 28,000 DBS procedures in the USA, up to 34% of the procedures were identified as electrode revisions, most often due to improper targeting and lack of effect. And this study is very important since it is a snapshot of the actual reality, not including only high-volume academic centers. Further, many patients with misplaced electrodes will of course not be offered a revision and are thus not included in the revisions above. So, when is an electrode misplaced? We have often heard the statement that a deviation of 1 mm is often well tolerated, 2 mm sometimes, and 3 mm seldom. I believe this to be quite true. However, in reality, misplaced electrodes are often very misplaced before revision is considered, as seen in these two studies by the group of Auken. 46% of the patients with the suboptimal effect of DBS were demonstrated to have misplaced electrodes, and these were misplaced with on average 6 millimeters. This is also in accordance with my own experience. I often get second referrals due to poor effect of DBS. In most patients, this is due to misplaced electrodes, and these are often 5 to 10 millimeters away from the intended target, as seen in these examples of intended STN DBS. It is also important to realize that the VIM and the STN are easy and forgiving targets. The VIM is easy since it cannot be visualized, and we have to rely completely on atlas coordinates. The STN is easy since it is so easy to visualize. They are further forgiving, at least in patients with tremor. If you target a patient with essential tremor in the VIM but end up in the STN, you will probably have a happy patient. Likewise, if you target the STN in a patient with tremor-dominant PD but end up in the VIM or in the zona incerta or in a number of other closely related areas, you will still have a quite happy patient. Other targets, like the GPI or the anterior nucleus of the thalamus, are not that forgiving. If you miss the target, you will get a poor effect. So, why are so many electrodes misplaced? In the first situation, the electrode do not end up where you aim. This can be due to inattention to details, procedure-related deviations, or incorrect interpretation of intraoperative evaluation. In the second situation, you have inaccurate targeting. You are not aiming at the correct target. The first situation is dealt with in the courses and lectures on accuracy and intraoperative evaluations. Here we will discuss inaccurate targeting. We need to remember that DBS is always based either on atlas targeting or visual anatomical targeting. In a second step, several intraoperative techniques can be used for evaluation of the target. With atlas targeting, we are placing the electrode according to the atlas and we hope for the best. Unfortunately, the atlas is not always in agreement with reality. Due to interindividual differences, atlas-based targeting will fail in a considerable number of patients. If we look at an example of targeting from atlas, then above we are using the midpoint of the third ventricle as our landmark. The target in the STN is in the atlas 12 mm lateral of this point and 3 mm posterior. We now identify the landmark on the patient's MRI and then the target point 12 mm lateral and 3 mm posterior of this landmark. Atlas targeting is necessary with targets we cannot see, like the VIM. The Stereotactic atlas is further helpful for interpreting what we are seeing in visual anatomical targeting. Atlas targeting is discussed in detail in the corresponding lecture, and if you're interested, you might also consult the lecture on atlas targets. With visual anatomical targeting, we look at a target in the individual patient and we place the electrode in what we perceive as the target. So, what is visual anatomical targeting? It is the identification of the target from visual patterns as seen on MRI, based on the assumption that the visual unit will correspond to the functional unit. We look at shapes, sizes, location, and relation to other structures in order to decide what we are seeing. How can we then delineate and define the target visually? Well, we can do this in a scientific manner by evaluating the location of implanted electrode contacts with the effects and side effects of stimulation. This is done in the example above, where we identify the area in blue with the best effect in 240 electrode contacts in patients with essential tremor. In reality, visual anatomical targeting is mostly based on clinical experience. The most studied target is of course the STN. In a recent review, it was demonstrated that the effect in relation to the actual location of the electrode had only been analyzed in a total of 260 patients. These patients were further divided into 13 different and very heterogeneous studies. We can all agree that it is probably an advantage to see what you're aiming at, and today it is not, or at least it should not be difficult to get MRI images where the target area is clearly visible in most patients. However, different observers will often interpret what they see differently. This is true both if we are looking at a cloud or at the STN. Concerning the latter, this is often due to differences in experience. If you do not know what to look for, then visual anatomical targeting can be quite blind. When I started with DBS 20 years ago, I had the best of teachers, but it still took a long time before I felt confident with the targeting procedure. Maybe this is because I am a fool, or perhaps visual anatomical targeting requires some practice. For the untrained eye, an MRI of the brain is more or less 50 shades of grey. You need to know how to connect the dots and lines in order to create a correct image. Our ability to realize the potential of a certain tool is dependent on who is using it. It is not reasonable to expect someone who has just started with visual anatomical targeting to have the same level of expertise as someone who has used this technique for 30 years. Much of what has been said so far is repeated in the lecture Targeting, an Overview. This is mostly intended for non-neurosurgeons, but I suggest that you read it cursively for pedagogic reasons. The next lecture deals with trajectories, and some details are worth repeating here. For the common targets, the entry point is normally at or within 10 mm anterior or posterior to the coronal suture at a laterality of 18 to 55 mm from the midline. One should avoid the ventricles and the sulci. We try to enter the cortex in a gyrus close to the dura if possible, and we need to remember that we are working with two-dimensional representations of a three-dimensional reality. When I am planning the trajectory, I will start with an entry point on the coronal suture and then adapt it in order to get an optimal trajectory. All other factors equal, I prefer to be at the suture and not much in front of it, due to aesthetic reasons and since the skin is getting thinner in front of the suture. With few exceptions, the entry point is within 10 mm anterior or posterior of the suture. The laterality is dependent on the target and ranges from 18 to 55 mm. And keeping the entry point within this area is advisable. The trajectory should enter a gyrus close to the bone and not pass through sulci or ventricle. Passing through a sulci increases the risk of encountering a blood vessel and causing a hemorrhage. Further, there is an increased risk of displacement of the electrode away from the intended target. If you need to pass the ventricle, then it is better to have a clean entry and to avoid sliding on the lateral wall. With a trajectory through a gyrus close to the bone, the brain will be pressed against the burr hole, thus reducing CSF flow. This will reduce brain shift and the risk for misplaced electrodes. So, how close to sulci? I prefer to pass through white matter only, but when necessary I will accept a trajectory passing at the border between white and gray matter, as in this example. Concerning the ventricles, I will try not to get closer than 2 mm to the ventricle wall, as in these images. Concerning the ventricles, it seems as if it is always possible to find an acceptable trajectory without entering the ventricles, with the exception of the anterior nucleus of the thalamus, where this is necessary. If you are entering the ventricles, it's better to do this in a straightforward manner, well away from the lateral wall. If you are sliding the electrode against the wall of the ventricle, this will exert a force deviating the electrode away from the intended target. Regarding atrophy, an atrophic brain do seldom pose a serious challenge concerning the trajectory. Severe atrophy is of course a contraindication for surgery, as is discussed in contraindications. However, in the atrophic brain, you might need to spend some time before you find an acceptable trajectory. Remember to check the whole trajectory for possible problems. In the example below, we see a cavernoma in the intended path of the right electrode. We try to avoid vessels along the trajectory if we see them. The question is, do you need contrast-enhanced images to identify the vessels? I have personally never used contrast-enhanced images for this purpose, except in the anterior nucleus. And I don't think that you need it if you're using the surgical technique described here. But it is probably of value if you are using microelectrode recording. What I have said so far is true regarding single tracks. But if you are using microelectrode recording with multiple tracks, then the diameter of your array will be about 6 mm, and to find a trajectory suitable for this can be very challenging. When we are looking at the images in the navigation system, we should keep in mind that we are dealing with the two-dimensional representations of a three-dimensional reality. One cannot create a three-dimensional understanding of an object from only one two-dimensional image. Before we had navigation systems, we used to choose entry point and trajectory based on coronal and sagittal images at the target level. Retrospectively, it is obvious that we often failed to understand the anatomy. And today, when we have navigation systems, I will never attempt to choose an entry point and trajectory without the help of the navigation system. However, even with a navigation system, it is still possible to focus too much on individual two-dimensional images. In the example above, you might from the coronal image on the left conclude that you will pass a sulci. However, as you can see from the images to the right, we are at that level not even close to the sulci, since we have been moving away from it in a posterior direction. Therefore, create an understanding of the area by looking at all projections and rely mostly on the probe's eye view. The trajectory is of importance also within the target area. Remember that even though your target point is a point, the electrode contact is distributed over a quite long distance. You will need to take the trajectory within the target structure in consideration when choosing a trajectory. This and other considerations specific to the individual targets will be further discussed in detail for each individual target. The next lecture deals with the anterior and the posterior commissures. This lecture is perhaps not very exciting, but it is important. Several colleagues whom I have visited have identified the anterior and posterior commissures several millimeters away from the real location, thus making atlas-based coordinates of very limited value. Even if we are using visual anatomical targeting, identification of the anterior and posterior commissures is still helpful. The more accurate you identify these structures, the better the correlation between the atlas target and the visual target on average. The intercommissural line, or the ICL, is the line connecting the AC and the PC in the midline. The mid-commissural point, or the MCP, is the midpoint of the ICL. Most stereotactic atlases are based on the MCP, and with a few exceptions, atlas targeting is done from this point. When identifying the AC and PC, look at both the sagittal images and the axial images. A typical axial representation of this area on different levels is presented above. Here we can follow the development step by step until we reaches the AC-PC plane, and then we continue further down. Practical exercises concerning trajectories and identification of the AC-PC are included in the next course, Calculations of Coordinates. And with this, I end this presentation. Thank you for your attention.